So this video is on necrotizing enterocolitis, or NEC. I'll try to balance the camera as best as I can. NEC is an acute inflammatory disease of the GI mucosa. It's infectious, and common complications associated with it are bowel necrosis and intestinal perforation. The mortality rate, unfortunately, for infants who develop this disease can range anywhere from 9 to 50%. And this is just a cross-section image of inflammatory lining of the bowel. Who gets this and when do they get it? NEC occurs in up to 10% of all NICU admissions, and 90% of these cases develop in infants who are preterm. So in those preterm infants, the condition will usually occur within their first 7 days of life. However, it can also appear as late as 30 days. And for term infants with NEC, it will usually occur 1 to 3 days after their birth, but it can also be delayed up to 1 month, like in the preterm neonate. This is a list of risk factors for the development of NEC, and I added little pictures off to the side for visual reminders. So for asphyxia and RDS, I included the image of the lungs. This is an umbilical artery catheter, exchange transfusion, the early enteral feedings or hyperosmolar feedings. This image is for the patent ductus arteriosus and other congenital heart defects, so this specifically displays the PDA. Polycythemia, anemia, a GI infection, and shock. And I'll make more sense of these risk factors as I go through the patho, which is right now. So the exact nature of the patho and etiology for NEC are unclear because there's so many contributing factors, as you saw on the risk factor slide. But there are 3 primary conditions that appear to be involved in the etiology of NEC, and those are intestinal ischemia, bacterial colonization, and enteral feedings. So with intestinal ischemia, it occurs as a result of hypoxia. So our risk factors like asphyxia, RDS, PDA, polycythemia, anemia, shock, etc., those are all implicated here. Basically anything that causes decreased or redistributed blood flow away from the GI tract. So hypotension and hypovolemia and severe stress, these are all concerns here as well. Then there's bacterial colonization in the infant's previously sterile GI tract. The common culprit organisms for this are Klebsiella, E. coli, and Clostridium. And finally, the third contributor is early enteral feedings, which we named on the risk factor slide. The feedings are thought to be implicated in the development of NEC because they either 1, provide a substrate for the bacterial proliferation, or 2, they increase oxygen demands in the GI tract during absorption, which leads to the hypoxia and ischemia in the bowel. The majority of infants with NEC had received some type of enteral feeding at some point prior to the development of this condition, so it's really a huge risk factor. And this is a picture of necrotized bowel, which is really sad looking. A lot of the signs and symptoms for NEC are very non-specific, and they're characteristic of several other neonatal diseases, so early identification can be difficult sometimes. But the first sign of NEC development in the neonate is refusal to feed. Remember that. Other generalized signs include decreased activity, hypotonia, pallor, recurrent apnea and bradycardia, decrease in O2 sats, respiratory distress, metabolic acidosis, oliguria, hypotension, decreased perfusion, temperature instability, and cyanosis. And the accompanying GI symptoms, which are more specific to NEC, include abdominal distension, increasing bile-stained residual gastric aspirates, vomiting of bile or blood, gross blood in the stool, abdominal tenderness, and erythema of the abdominal wall. And this is an image of an infant who's displaying the abdominal symptoms. The diagnosis of NEC can only be confirmed through radiographic examination, and this exam will reveal bowel loop distension, pneumoperitoneum or pneumatosis intestinalis, which is just air trapping within the peritoneum or the walls of the intestines, and then portal air, which is air trapping in the hepatic portal system. Other supportive labs that may be drawn would include a CBC with differential. The CBC would show a white blood cell count that's either elevated or depleted. Coag studies would show abnormal platelet counts, thrombocytopenia, and perhaps even DIC if the NEC has progressed far. ABGs are done to determine hypoxemia and metabolic acidosis. Electrolyte imbalances occur because of the leaky capillaries and third spacing fluid shifts in the abdomen, and a blood culture is done to determine septicemia and organism identification. So the primary goal in the management of NEC is to prevent 1, the progression of the disease, 2, perforation of the bowel, and 3, ultimately shock. If NEC is even suspected, the first intervention is to discontinue any oral or tube feedings because you need to rest the GI tract. Then they place an orogastric tube, and it's hooked up to intermittent suction to allow for gastric decompression, because there's a ton of air accumulating in the bowels and the peritoneum as a byproduct of the invasive bacteria's metabolism. TPN and antibiotic therapy are initiated per provider's orders. If there is a perforation or if the neonate's condition begins to deteriorate rapidly, then surgical resection of the bowel will be necessary. Oh, sorry again. And NEC is a very infectious disease, so pristine hand washing is required before and after all interactions with this neonate, because we don't want to transmit the infection to other babies on the NICU unit. Finally, a huge role that we have as nurses is to provide emotional support for the family. And we can do this by offering them detailed explanations of the procedures or treatments that their child's receiving, helping them through the decision-making process, and ultimately supporting them through their grieving periods. So final facts, or last comments on NEC. An important fact about this condition is that it's extremely rare among infants who are exclusively breastfed. So breast milk appears to have a protective effect against the development of the disease, which is great. Also, there's been a lot of promise shown for the use of probiotics in reducing the risk of NEC. So parents and providers for any infant who might have risk factors for the development of this disease would probably want to consider prophylactic probiotic therapy for them. And that is all. If you have questions, post them, and I'll try to answer them as best as I can, and I'll try to post this PowerPoint too.